Next slide is randomization. Randomization, as we know, is the heart of the randomized controlled trial. In this part, we are going to see why we randomize, how we randomize, and what are the various uses of randomization. As you see, you had already learned about a procedure called as matching. Matching was used so as to make two groups comparable on the basis of certain pertinent demographic variables. For example, we had cases and controls, and we matched these two groups for age, we matched for sex, and you might have also matched them on a couple of other counts. Now the problem with matching is that when we match, we only can match factors that are known to affect the prevalence of the disease. Surely our knowledge about any disease is far from complete. There are many factors which affect diseases, but we do not know them. To match these factors, we use randomization. When we randomly assign people to either of these two groups, there is an equal probability that a 15-year-old boy goes here, a 15-year-old boy goes here. If a male goes to this group, a male goes to this group also. What happens is, what we are matching not only the known factors but also many unknown factors. So the known as well as the unknown factors which are important as far as the disease is concerned are automatically getting matched. So the analogy that we used earlier, comparing apples with apples, we are almost sure that on the both sides of this group we have apples. So we are comparing like with like. The only difference here is the intervention that we will introduce in the future. So we are very sure that the two groups are comparable, and the only difference between these two groups in the future will be the intervention that we do. So randomization is the statistical procedure by which the participants are allocated into two groups called as study group and control group. Selection bias is minimized, almost eliminated, because I cannot determine which subject goes to what wing of the study, whether he will be into the experimental group or he will be into the control group. I cannot determine that. It is randomly assigned. It is definitely better than matching for the very same reason that I explained. Known as well as unknown factors are matched, and it is best done by using a table of random numbers. Now what is a table of random numbers? Table of random numbers is a table which is generated by the computer. It is preformed table. The computer uses its analogs that does already fit into it, and it gives out any random number and it is printed onto a sheet. The table of random numbers can also be found at the back of statistical manuals and books, and you can use, for that matter, any random number available in nature, like your telephone directory. So any page you open, the number that you have can be used as a random number, and the patient is allocated either to a control or a experimental group. Other method of randomization is you can have chits, that is called as the lottery method. You either write on the chit experimental group or control group. You can have the mixing of the chit. When a patient comes in, he picks up a chit. Whatever chit he picks up, he is automatically assigned to the particular group. Here you have noticed that the selector is in no way in a position to select the candidate. So the candidate automatically selects his group. The investigator has no control on the selection of the subject. Assumptions of statistical tests are validated when we do randomization. When we will go to statistics, we will see that there are certain tests, and these tests have some underlying assumptions about the populations to which they are applicable. When we do randomization, one of the important assumptions that these tests make are that the underlying population is random, and when we do randomization, that very assumption is taken care of. So these statistical tests are very much apt for these RCTs then. When do we randomize? Selection criteria are met, informed consent is available, we randomize after that. Subjects are likely to comply to the treatment and follow up. So all these criteria should be fulfilled. If any of these criteria is not fulfilled, it is not a very wise decision not only to randomize but to include the subject in your study. As we saw, these are long-term studies. Follow-up is required. Attrition will be a big problem in case these parameters are not met. Then is the stage of manipulation. Manipulation means the intervention that you do into the group. Looking at the board, you have two groups. In RCT, although you will not have cases and controls, you will have two groups which are experimental group and control group. Why is the name changed? The name is changed because I am going to intervene for this group and I am not going to intervene for this group. Okay, so this group will receive a placebo. What is a placebo? Sugar, chalk powder, okay, anything. A substance which has got no physiological activity or at least no activity concerned with the disease. That is a placebo. So, you ask why to give a placebo? Why can't we just give medicine to the experimental group and no medicine to the control group? The answer is, when you know that you are taking some medicine, your mind automatically plays games with you and you subjectively feel better. This sense of betterment is called as the placebo effect. When a drug is given to you which has got no pharmacological or physiological action, but you still feel better, that is what is called as a placebo effect. Also, the second objective of giving a placebo drug is that the background rate of reactions is calculated. Now, what is this background rate of reactions? Background rate of reaction is the opposite of placebo. When you take a drug, somehow you feel that maybe my arm is itching or I have a headache or I am bloating, some or the other complaints. So these complaints will be generated in the experimental group also. These complaints simultaneously would be generated in the control group also. So both of your purposes are solved. If people are falsely feeling better, you know that. If people are falsely feeling worse, you know that. That is why a placebo is given to the control group and we do the intervention in the experimental group. As we had discussed at the start of the lecture, remember, this intervention can be anything. It can be a new drug, it can be an injection, it can be any new product in the market. So anything new that is introduced, we use RCT. And as I already told you, nowadays the most common indication of doing an RCT is to launch a new drug. So we'll take that example. In the experimental group, we will give the drug. In the control group, we will give a placebo. Okay, so these people get drug, these people get placebo. Okay, so that is what we do with them. This very intervention is then called as manipulation. So you know now what manipulation is. We do a intervention. This intervention can be anything. We are taking the example of a drug. The control group receives a placebo. Why placebo? I want to know if people are feeling falsely better, and I also want to know that if people are unnecessarily cribbing about the treatment. So I get background rates of both. For a drug to prove effective, it should have an efficiency over and above the placebo effect. Say for example, this is the baseline. Now the effect of placebo would be, or is at least expected to be, very much similar in both of the groups. Since the groups are demographically comparable, we also expect that the placebo effect is the same. If I want now to conclude that the drug is working, the effect on the experimental side of the chart should be over and above the effect of the placebo. This is the placebo effect, okay, equal on both the sides. The effect on the experimental side should exceed the placebo effect much more, then I can say that okay, the drug is working, it is functional. So this is the stage of manipulation wherein you introduce a third factor which is not common to both the groups. We did randomization, we matched the groups. I introduced the third factor which was really new, which was a intervention. Then we follow up the study, we collect data, and ultimately we assess the results. Both positive and negative outcomes should be sought. Again, this is pharmaceutically important. So sorting out of positive and negative outcomes is pharmaceutically important because we just don't want to know how much better the drug is, but it may so happen that the drug is deadly or it may have a lot of side effects. So I also want to simultaneously know what are the side effects of the drug, or in other words, is it even significantly worse than the existing treatment? So there can be two possibilities. Either the drug is better or the drug can also be worse than the existing treatment. So also positive as well as negative data is meticulously recorded. Bias that can creep into a randomized control trial. As already discussed, there can be a placebo effect. Placebo effect is, again, you get some medicine, you feel better. The medicine simply does not work. After a year, I tell you that you were just eating sugar powder. Okay, so this is also one of the problems with RCT, that people will have this complaint that they are not ready to eat sugar powder, I need the real drug, and they will pressurize the investigator to put them into the experimental wing. What should you do then? Say your relative comes to you and he says that I want the drug, please put me into the intervention group. If you do that, you violate the whole randomization process. The very essence of randomization is that the allotment should be really random. If I subjectively put a person into intervention or control group, I am voiding randomization, the demographics would not match, and all the benefits that we had discussed for randomization would be lost. So the person should be really randomly allocated to a group, and the person who is taking the medicine should not know whether he is taking the medicine or he is receiving a placebo. So that is the first bias, subject variation. Second bias is observer variation. If I am the doctor, I am administering drugs to the patient. Say for example, the patient is of rheumatoid arthritis. You already know rheumatoid arthritis demonstrates a lot of waxing and waning. So the disease goes up, the disease comes down. So in such a case, when I give a drug to the patient, and if I am a doctor, I know what the patient is taking. Is he taking a medicine or is he taking a placebo? If the patient is taking a medicine, I poke him. I ask him, you must be surely feeling better now. How are you feeling? You look better from yesterday. You look red, you look happy. Okay, so I probe him. I probe him towards telling me that he is okay. And the patient says, yes, I am feeling better than yesterday. Similarly, if you know that the patient is just having sugar powder, you probe the patient and say, I think there is no difference in your health status from yesterday. So you are yourself introducing a bias into the study. This is called as the observer bias. Lastly, there can be a investigator bias. What is an investigator? Investigator is the person who actually does the statistical analysis. He is also the person who is in charge of the study. Sometimes what happens is the investigator can subconsciously give a favorable report in favor of the drug, because as I said, the whole purpose of this thing is to give a favorable report to the drug manufacturing company. So the investigator, if he knows a group is taking medicines and that is the marketed drug, then he could unconsciously give a positive report. What do we do for this? There is something which is called as blinding that can help us and can solve a lot of problems. Blinding is a gruesome word, but we are not literally going to blind somebody. What we are going to do is just blind them to the knowledge of whether they are taking medicines or they are taking a placebo. As you can see, you have three kinds of blindings. There is single blinding, double blinding and triple blinding. Again, sitting duck MCQs, do not miss easy marks. What is single blinding? Single blinding is when the patient himself does not know whether he is in the control group or the experimental group. Is single blinding common? Of course it is. The very essence of RCT is single blinding. I cannot have people knowing if they are taking a placebo or a drug. That is no study, that is not an RCT. So essentially single blinding is done. The patient should not know if he is taking the drug or he is taking a placebo. Double blinding. The double blinding is said to be done when the patient does not know what he is taking and the doctor administering the drug also does not know what he is taking. Now you may have thought that the doctor would see at the pills and know if he is giving a pills or he is giving placebo. To safeguard against this, the drug is exactly made to look like the placebo, or you can say vice versa. The placebo is made to look exactly like the drug. Say for example, if I am giving a medicine which looks like this, I'll also make a placebo tablet which exactly looks like this. If I am giving a injection to the intervention group which is red in color, I'll be making an exactly same placebo with red colored injection. So even the doctor would not know if he is giving the actual drug or the placebo. This is called as double blinding. Coming to triple blinding, extra precaution. Patient does not know what he is taking, doctor does not know what he is giving, investigator does not know what he is testing. So even the investigator, the high boss who is running the study, he does not know if he is dealing with the data of intervention group or he is dealing with the data of the experimental group. So he is completely unbiased because he does not know what he is dealing with. Triple blinding study looks fine. Practically this is usually not done. What is usually done is double blinding. That means the patient and the doctor does not know, but the investigator, as he collects data, he knows the data belongs to which arm of the study. So this is blinding. Compliance, very essential issue as far as our RCTs are concerned. Compliance, again, the technical definition is very difficult. What matters to you is how much tablets or pills or how much prescription has the patient actually taken of what you had prescribed. That is compliance. Broader understanding of the term compliance is how much has the patient adhered to the guidelines of the physician. So broadly, that is what compliance is. Strategies to enhance compliance: selection of study population who are interested and are reliable, frequent contact with the study subjects, calendar packs of medication, and use of incentives. Remember, use of incentives is again tricky. What incentives you can give to the patient are basic remuneration for his food and his transport. Apart from that, you can't monetarily reimburse him for taking part in the study. The reimbursement cannot be like a cash prize for participating in the study, because then the participants would be skewed. You won't be truly randomizing the population. Advantages of the RCT: selection bias is controlled, almost minimized. If you don't give in to the pressure of your friends and relatives to put them into one arm or the other, selection bias is almost eliminated. You really do not know which arm the patient will go. You have no control over it because the whole process is randomized. It balances potential confounding factors. Now these confounding factors, as we had seen on the board, might be known, they might be unknown. So very good, it's like divine randomization. God has done this. Marriages are made in heaven, something like that. So the matching is done by God. I don't know what I have matched. I have randomly put it, and most likely it is equally matched. So the factors which I know, factors I don't know, everything is matched. It allows standardization of eligibility criteria, and it is statistically a very efficient design because we saw all the assumptions that the statistical tests make are fulfilled while we use a randomization design. Disadvantages of RCTs in short: they are very expensive and complex. Obviously, if you look at the pharmaceutical market, pharmaceutical companies have to initially invest billions of dollars. I am talking about billions and not millions. They have to invest billions of dollars and decades of research for getting permission for a single therapeutic agent in the market. So they are absurdly expensive and very complex. Most of the times these studies are multicentric. We saw multicentric means they are carried out at various centers simultaneously. The whole design of RCT is open to ethical challenges. This is a big problem again. As I told you, for cohort the same holds true for RCTs also. Say for example, you are testing a new drug for syphilis, and you come to know that this drug not only cures syphilis, maybe it even prevents syphilis, and your study is midway. Ethically, you are bound to stop the study midway, and you are bound to submit your findings to the committees and publications so that this drug can be fast-tracked and the benefit of this drug can be passed on to the people at large as soon as possible. Good for the community, but then you have a problem that your study is not complete. Also, the second side of the coin, the drug is very effective, but in the very same study, who is getting the drug? These people are getting the drug. Who is not getting the drug? These people are not getting the drug. So ethically, am I not wrong in withholding the drug from these people? So that is also an ethical problem. If I come to know that the drug is astoundingly good, I condemn these people of the benefits of the drug. This might not sound very serious to you at this stage because you might be thinking of very common diseases, malaria, fever, cholera. I am not disregarding these diseases, but there are more serious diseases also. Say for example, cancer. If I come to know that this drug is excellent in what it is meant to be, am I not condemning these people to death for the sake of my study? At that point of time, the ethical concerns are mind-boggling, and I am obliged to stop the study. Lack of representativeness. This is again a disadvantage. I cannot really guarantee that the population which volunteers for the study is representative of the reference population. Quick check. What is the reference population? Reference population is the population to which the findings of the study are applicable. I gave you the examples of males and females. If the drug acts on both males and females, the reference population can be the whole population of planet Earth. Okay. So lack of representativeness. Say for example, you give an ad in the paper that I want to test a protein shake for increase in body mass. So you are increasing a muscle mass with a protein shake. Who is likely to come forward for this study? Anybody who is very thin, who wants to grow his muscle mass, would first come to you and volunteer for the study. What will he do when he has the protein shake? He'll exert. Okay, so the muscle mass will automatically increase. This is something wherein you can't assure the representativeness of the person. If the same protein shake is taken by a layman, maybe he won't benefit that much. But this guy who is already motivated to build a body is going to benefit more. Not because of the protein shake, but he has been working out. So the representativeness of the sample can sometimes be a concern. Sometimes RCTs are impractical. You know that there can be numerous reasons for this. Natural history of disease is too long. The drug works at specific stages of the disease. It takes too long for any meaningful differences to come out. These are some of the common reasons why RCTs can be impractical. Some other types of studies that can be done are field trials, preventive trials, risk factor trials, community trials, and evaluation of health services. These are some of the other applications for which this study design can be used. Crossover study. This is something interesting. What is a crossover study? Crossover study is when I have less money or I don't have much of patients. So I'll have to utilize what is given to me. So I use a crossover design. Each participant is a case acting as his own control in a crossover study, and it accounts for potential confounders, example matches of age, sex and genetic susceptibility. Exposure status immediately before the event or outcome is compared with exposure at some time prior to the event. Acute exposure and outcome are taken into consideration, and recall of prior exposures could be a problem that is taken care of in the crossover design. We will be seeing crossover designs in detail in the next lecture. Thank you.